all in and make this a deep, structured, and exam-ready full detail note on amyotrophic lateral sclerosis, ALS, with expanded explanation. 1. Introduction. Amyotrophic lateral sclerosis, ALS, is a progressive, fatal, neurodegenerative disorder primarily affecting motor neurons, the nerve cells responsible for voluntary muscle control. The disease is marked by gradual muscle weakness, wasting, and paralysis, while sensory functions and cognitive abilities are usually preserved, though cognitive changes occur in some. It was first described by French neurologist Jean-Martin Charcot in 1869. In the United States, it is often called Lou Gehrig's disease, after the famous baseball player diagnosed in 1939. The disease has a relentless course. Most patients die within 3 to 5 years from symptom onset, usually from respiratory failure. Multidisciplinary care can significantly improve quality of life and survival. Number 2. Definition. ALS is defined as, open quote, a progressive motor neuron disease characterized by degeneration and death of upper motor neurons in the brain's motor cortex and lower motor neurons in the brainstem and spinal cord, resulting in progressive weakness, muscle atrophy, spasticity, and eventual paralysis, with death typically caused by respiratory failure. Close quote, key points, upper motor neuron, UMN damage, spasticity, hyperreflexia, Babinski sign. Lower motor neuron, LMN damage, muscle weakness, wasting, fasciculations. Sensory system, usually spared. Autonomic system, usually preserved until late stage. Number 3, etymology. Amyotrophic, A equals without, myotes muscle, trophic equals nourishment, no muscle nourishment, referring to muscle wasting. Lateral refers to the lateral corticospinal tracts in the spinal cord that degenerate in ALS. Sclerosis, hardening due to gliosis and scarring from neuron death. 4. Epidemiology, incidence 1.5 to 2.5 per 100,000 year globally. Prevalence 5 to 8 per 100,000 population. Age of onset, sporadic ALS, typically 55 to 75 years. Familial ALS earlier, often in 40s. Gender, slight male predominance, MF 1.2 to 1.51, gap narrows with age. Geography, slightly higher rates in Europe, North America, and Japan. Clusters reported in Guam and Kii Peninsula, Japan, possibly linked to environmental toxins. Survival, median 3 to 5 years from onset. The taught 10% survive 10 years. Some, like physicist Stephen Hawking, survive decades. Number 5, types. By etiology, 1. Sporadic ALS, 90 to 95% of cases, no family history. 2. Familial ALS, 5 to 10% of cases, inherited, often autosomal dominant. Common genes, C9orf72, SOBP, FUS. By initial presentation, 1. Limb onset ALS, 70%. Weakness in arms, legs first. 2. Bulbar onset ALS, 25%. Speech and swallowing problems first. 3. Respiratory onset ALS, 5%. Breathing problems as first symptom. SOSs. Exact cause unknown, but proposed mechanisms include genetic mutations, especially in familial ALS. Glutamate excitotoxicity, excessive glutamate damages motor neurons. Oxidative stress, free radical injury to neurons. Abnormal protein aggregation, toxic inclusions inside neurons. Mitochondrial dysfunction, impaired energy production. Neuroinflammation, immune-mediated neuron injury. Axonal transport defects, impaired delivery of nutrient signals in neurons. Environmental exposures, pesticides, heavy metals, solvents, suggested but not proven. Number 7, risk factors. Age, middle-aged and older adults. Male sex, slightly higher risk until menopause. Family history, especially first-degree relatives. Genetic mutations. Smoking, especially in women. Military service linked to higher ALS rates. Traumatic brain injury. Occupational toxin exposure. Intense physical exertion. Controversial but noted in athletes. Number 8, complications. Progressive paralysis, wheelchair bedbound state. Dysphagia, malnutrition, dehydration, aspiration, pneumonia. Respiratory failure, most common cause of death. Speech loss, anarthria, communication difficulties. Emotional ability, pseudobulbar effect. Depression, anxiety. Caregiver burnout. Number 9, pathophysiology. 1. Neuron degeneration. Upper motor neurons in motor cortex. Lower motor neurons in brainstem and spinal cord anterior horn. 2. Key processes. Excess glutamate, neuron death. Oxidative stress and mitochondrial injury. Abnormal protein folding, TDP43 inclusions. Impaired axonal transport. 3. Progression, denervation of muscles, atrophy and weakness, loss of voluntary movement control, respiratory muscle failure, death. 4. Sparing of sensory neurons, ocular muscles, usually until late, bowel bladder function until late. Number 10. Signs and symptoms, upper motor neuron UMN signs, spasticity, hyperreflexia, Babinski sign. Lower motor neuron LM signs, muscle weakness, often asymmetrical, fasciculations, atrophy, cramps. Bulbar symptoms, slurred speech, dysarthria, difficulty swallowing, dysphagia, excess drooling, rhea. Respiratory symptoms, dyspnea, orthopnea, weak cough. Late stage, paralysis of all voluntary muscles, preserved eye movement and sensory function. 11. Medical diagnosis diagnostic tools. Clinical exam, UMN plus LMN signs in multiple body regions. Electromyography, EMG, widespread denervation and reinnervation. Nerve conduction studies, NCS, differentiate from neuropathies. MRI, rule out spinal cord compression, tumors, MS. Blood and CSF tests, exclude metabolic, infectious, autoimmune causes. Genetic testing, for familial cases. LS-Scorial criteria, gold standard diagnostic criteria. 12. Nursing diagnosis, impaired physical mobility, ineffective airway clearance, impaired verbal communication, imbalanced nutrition, less than body requirements, risk for aspiration, anxiety, depression, caregiver role strain. Number 13. Medical management disease-modifying drugs. Riluzole inhibits glutamate release, prolongs survival 2 to 3 months. Edaravone, antioxidant, slows functional decline in some patients. Symptom control, spasticity, baclofen, tizanidine, cramps, quinidine, mexiletine, sialorrhea, glycopyrrolate, botulinum toxin. Depression, SSRIs, TCAs, respiratory support, non-invasive ventilation BiPAP, tracheostomy with mechanical ventilation, late stage. Nutritional support, PEG-G feeding to prevent malnutrition, aspiration. 14. Nursing management. Monitor respiratory status and oxygenation. Maintain airway, suction, position, ventilation support. Nutritional monitoring and PEG care. Skin integrity maintenance, pressure sore prevention, mobility assistance, physiotherapy collaboration, speech communication aids, emotional support, and caregiver education. Number 15. Treatment options, medications, riluzole, edaravone, symptom-targeted drugs. Therapies, physical, occupational, speech. Assistive devices, wheelchairs, voice synthesizers, ventilators. Nutrition, PEG tube when oral feeding unsafe. Palliative care, end-of-life comfort measures. 16. Psychosocial intervention, counseling for patient family. Support groups, advanced care planning, ventilation, feeding tube decisions, social worker involvement for home adaptations and finances, respite care for caregivers. 17. Prevention, no proven prevention due to unknown cause. General health measures, avoid smoking, reduce toxin exposure, use protective gear in hazardous jobs, maintain a healthy lifestyle. 18. Conclusion. ALS is a rapidly progressive, incurable neurodegenerative disorder with devastating physical and emotional impact. While its cause remains incompletely understood, research into genetic and molecular pathways is offering hope for future treatments. Current management focuses on slowing progression, alleviating symptoms, maintaining independence, and supporting emotional well-being through a multidisciplinary approach. Early intervention, patient education, and strong caregiver support are essential for optimizing quality of life. Thank you. Have a nice day.